time doing that sometimes. So typically what I work on first is just more of a stabilization. So I just will kind of grip the knee with my knees together and facilitate the sit to stand.
So she's in front versus on the side.
Yeah. So I'll get her to lean forward, and we're going to come up to stand. Ready? And then I can kind of slide up if I'm able. And then we sit back down. And then I can gradually move to, sorry, I can gradually move, like if I'm looking for like patellar tendon activation, I can gradually move to where I feel like she's strong enough that I can maybe use my hand down there or something like that.
So what happened during that is, because Daly's in front of me, I have less of that movement to come forward, so I did have a little bit harder time actually transitioning forward, but she felt comfortable being in front of me to keep me safe, whereas Professor Lesh is on the side. You're going to have more control of your patient when you're sitting in front. So I oftentimes will start in front, although I'm taller, just so I know, okay, I can just bear hug this patient and we can come back down if we need to.
The patient feels safer with the person in front. So that may be a consideration you'd factor into it.
One trick I'll use to help with that lack of space here is if Daly's going that direction, I'll tell the person, try to bring your head over my shoulder. So they feel like they can still lean forward, and I've given them permission, like, come on over here, you know, you can get closer. And so that way you're not necessarily an exact midline, but you're close enough, and they can still lean forward pretty well.
I have often cue my patients to touch their shoulder to my shoulder, and that's just kind of a nice point of contact too. I'm not really doing anything with my shoulder, but it keeps them coming forward, and then I guess it kind of does help them lift up once we get to that point where my shoulder starts to lift, theirs does too.